Adrenergic blockers. I said blockers gonna block. You cannot block if there is no initial excitation. These are competitive blockers. And you don't want to block something that's not really excessive. Blocker can block the basal activity, but when you clinically use a blocker, it's usually when it's really high. Then you want to use blocker to block it. Does that make sense? So in situations where sympathetic output is really high, then you want to block it. So I said there are alpha and beta blockers. You can see a pattern here. Okay, so alpha 1 vasoconstriction, when it's blocked, it causes vasodilation. Beta 1 heart stimulation, when that's blocked, it causes heart suppression. So can we name all the blockers? Maybe, maybe not. On the alpha side, it was all P's, PPP, right? So the first one was phentolamine and phenoxybenzamine. Phentolamine, I said, is a reversible or competitive blocker, so the curve shifts to the top right, so that's PT. Phenoxybenzamine is irreversible, so it's lower curve, PB. And I think Sketchy says it's Phoenix. Phenoxybenzamine, you can't get rid of it, okay? So it's irreversible. What's more important is alpha-1 selective blocker, prazosine. Zosine is alpha-1 blocker. Beta side, the prototype was ol, right? Ol is beta blocker. And A through M, if it starts with from A through M, that's beta 1 selective. If it's not OL, but similar to OL, it has activities in addition to beta blockade. So labetalol and carvedilol, okay? So can you all remember this? I want you to take a blank sheet of paper, write alpha X, beta X, and then write P, 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 all. That's it, okay? P, 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 all. All right. Okay, so when you have alpha blocker, again, blockers are used in cases where there is too much activation. So if your blood pressure is really high due to abnormal vasoconstriction, you want to revert that, right, by vasodilating, blocking alpha receptors. So it would be hypertensive crises where you would use alpha blocker to vasodilate and lower blood pressure. In other case, BPH, where it is abnormally constricting, right, your output, then you want to relax that muscle. That would be alpha-1 selective blocker for BPH. Okay, so here's a figure that you can read. In using alpha blocker, there are two main side effects: reflex tachycardia and orthostatic hypotension. So reflex tachycardia and orthostatic hypotension. I explained this reflex tachycardia when alpha-1 was constricting the vessel. You block it, you get relaxation and drop in blood pressure. Your baroreceptors are normally functional in all of you. That maintains your blood pressure every second of every day. But in this particular case, your baroreceptors are trying to function by, oh, I sense the pressure's dropping, let's pump it up, okay? But it cannot pump it up at the blood vessel level because alpha receptors are already blocked. I said when blocker's gonna block, when you add blocker, additional stimulation is also blocked. So you can't do it there. So what's the second part of sympathetic activation? Beta 1 heart stimulation. So it goes extra to stimulate the heart. So you get a big jump in heart rate. That's reflex tachycardia, okay? The other thing is orthostatic hypotension. I tried to bring my balloon man, but it was leaking already. It's done its job, okay? So I took a picture of it. So when you stand up, your blood pools in your lower body. It happens all the time, but because it constricts the veins and arteries in your lower body as a reflex mechanism, you can actually have blood coming back to your brain. But when alpha receptors are blocked, that part is not happening, so you lose blood to your lower body, you feel dizzy, fainting, etc. Okay, those are the alpha blocker effects. Vasodilation, then you can have lower the blood pressure, or you could treat abnormal constriction of your urinary path. Okay? Beta blocker, main thing, it blocks heart conditions. It's kind of weird when you learn about it, but anyway, it's used very widely. But the problem is beta 2 blockade can be bad. Okay, so initially the prototype blocker was what? Propranolol. It's beta 1 and beta 2 blocker. So it had really good functions, but it was problematic in a couple of different conditions. One, asthma patients, the other was diabetic patients. Okay, so it blocks heart function. So heart suppression is what beta blockers do. But in addition to beta 1 blockade, if it blocks beta 2 in the bronchial smooth muscle, it's a problem. If it blocks beta 2 glycogenolysis, that's also a problem. So people tend to use beta 1 blocker more nowadays. Okay, does that make sense? So you can almost imagine a question here. This guy has asthma. He's using propranolol. What should he use, really? Right? So then it would be beta 1 selective blocker. Or this person has diabetes and you're trying to use beta blocker. What should you prescribe? I would list something like prezosine, propranolol, metoprolol, labetalol. What's beta 1 selective? This is a very common question. There's additional blockade of beta 1 renin release. It's a really important mechanism. You will learn more about it in the renal section.